Thank you for coming out and welcome. Welcome to the 6th Annual UCSF School of Dentistry Global Oral Health Symposium. My name is Benjamin Chaffee. I am the director of our School of Dentistry's program in Global Oral Health, and I'm really delighted to get today's event started. I'm so happy to see people in the room and a lot of energy and anticipation for what I hope is going to be a really exciting program. For the afternoon, we've lined up a great schedule of speakers, and while the format is a bit more traditional, a lecture to an audience, I hope that you'll look for opportunities to make this interactive and engaging. Take notes, talk to your neighbor, converse about the topics and the questions ranged during the break, ask questions of our speakers. We'll take 1 or 2 questions after each talk, and then we'll bring all of our keynotes back for a panel for more interaction with the audience. Keep that conversation going. For the afternoon, we've lined up a great schedule of speakers, and while the format is a bit more traditional, a lecture to an audience, I hope that you'll look for opportunities to make this interactive and engaging. Take notes, talk to your neighbor, converse about the topics and the questions ranged during the break, ask questions of our speakers. We'll take 1 or 2 questions after each talk, and then we'll bring all of our keynotes back for a panel for more interaction with the audience. Keep that conversation going. And to that end, I hope that we can continue spreading the message and the topics that we cover today. Share what you've learned today with your peers. And to that end, an event like this takes many people to put together and a whole lot of effort. At the end of the program, we'll have some official thank yous, but I do want to make specific mention to our co-sponsors at the Philip R. Lee Institute for Health Policy Studies. Thanks to them, we are going to be able to have that video recording and share this with a much broader audience. So thank you to them. And for those of you who've been coming to these symposia over the years, you know that each year we look for a theme, a topic that's going to tie together our speakers. And very timely, today we'll be discussing inequalities in oral health. And the conversation about inequalities, perhaps my perception of it, it's reached very high levels in this country, in this community. What does that mean? What does that mean now? What does that mean for our future? What is it that makes differences from one group to the next an inequality, a disparity? What makes them unjust and unfair? And what should we do about that? What should we do as individuals? What should we do as members of larger communities? Here on campus at UCSF in San Francisco, we sit in the middle of what in many ways is an unprecedented concentration of technological advancement and wealth. And yet at the same time, we need look only at our patient population, at our neighbors immediately around us, to see just staggering prevalencies of what are largely preventable diseases and ailments. So it's not surprising in the last year, our chancellor named equity and inclusion as one of the 4 central objectives, one of the 4 central pillars of what we stand for here at UCSF. And so our theme today has 2 parts when we talk about oral health inequalities. We talk about moving from measurement to action. And that direction, going towards action, in no means is intended to diminish the importance of measurement. We'll talk quite a bit about what it means to document and capture inequalities, to define them, to push that conversation forward. It gives legitimacy, it gives validity, it makes the inequality something that's real. And it gives us clues about how they form and what we might do about them. And then comes the action. Our speakers will talk about models that have been successful, approaches that can be perhaps copied and expanded or improved. We'll also talk about actions yet to be taken, things that we need to be doing in the future if inequalities are to be reduced, mitigated, avoided, and eliminated. So I greatly thank you for your attention, for your attendance today. I hope you get a lot out of the experience. And I'd like to present our prestigious dean, Dr. John Featherstone, to give a few words of welcome as well. Certainly without Dr. Featherstone's leadership and support, there would be no program in global oral health at our School of Dentistry. There'd be no symposium today. So please give him a warm show of thanks as he comes up to the podium.
Well, it's my pleasure to welcome you all here. Interesting to look around the room and to see that, I don't know what we've got here, probably half the room filled, which is great, but there were 150 people registered to come today. So next year we're going to charge $100 to register, and we'll see whether that makes a difference to those who come. We've got quality in the audience. We've got quality in the presenters. Absolutely, we're in for a fantastic performances this afternoon. I'd like to apologize to those who have come from out of town. It's a little bit like a treasure hunt trying to find this building now, but that's because we live in an earthquake belt, and the two buildings immediately over here have been rated as seismically unsound. So one of them has been totally gutted, and over the next 2 years will be rebuilt internally. And we made that decision on campus to retain those two buildings rather than tear them down and rebuild them. And that's what's going on. So we have to go around those areas. So my apologies for that. But if people cannot negotiate that small part, how can we negotiate the world? That's my message here today. So again, welcome. I'm thrilled to be standing up here with our 6th Global Oral Health Symposium. And when John Greenspan and I talked about it some years ago, it was a dream, and it's now not a dream anymore. It's just what we do every year. And I'd like to thank John for his leadership in getting these things going. And I'd like to personally thank Ben and his team for putting together this symposium today. And without further ado, I'd like now to call on John Greenspan to come up and introduce our first speaker. So thank you all.
Richard Watt was born in the far north of the British Isles, the tip of Scotland. Pretty cold and wet up there, but he seems to have survived. That part of the country was ruled by the Norwegians for several hundred years. We think of them as the Vikings, so you'll have to make your own mind up as you hear his talk. He started a progressive series of migrations south, moved with his family to Aberdeen, went to Edinburgh for his university and dental school experience, and then went out into the trenches near Liverpool for several years as a community dental officer and learned what it was really like, what the health of the population was, the inequalities, the challenges of dealing with dental disease, and decided he needed to make his mark. Moved to London, to University College London, where he worked with Aubrey Shyam. Many of us think of Aubrey, he died quite recently, as the father of modern dental public health and, in fact, as the father of global oral health, although he would never have claimed that. In the then department run by Sir Michael Marmot, who was really, in many ways, the seminal investigator on the social gradient and health, which Richard will, I'm sure, allude to. When Marmot stepped aside and Aubrey stepped aside, Richard took not only Aubrey's professor appointment in dental public health, but also the head of that institute, which is essentially the School of Public Health of University College London, one of the premier universities in the world. So he does us great distinction as a dentist by leading a major unit in the mainstream of public health and global health. His devotion to global oral health inequalities and through that to the whole issue of social determinants of health is legendary, and we're very privileged that he will share that with us. Thank you, Richard.
Thank you very much for that very kind introduction, John, and I'd like to thank Ben for the invitation to come along here. And it is a great pleasure to be in San Francisco. This is my second visit to San Francisco. In London at the moment, it's still quite grey and cold and so wintry. So to come here yesterday in the sunshine and warmth is a great pleasure. So, and it's an enormous pleasure also to be part of this global series of lectures, because I think this is the 6th one, and you've had some very high-profile speakers previously, so it's very nice to be included in that group. So what I'm going to be doing in the next 40 minutes or so is I'm going to be talking about really the issue and overview of oral health inequalities. And as John has mentioned, as Ben has mentioned, the issue of oral health inequalities, of disparities, is one that is centre stage both in terms of policy, in terms of education, and in terms of action in many parts of the world, including the US. And what I would like to do in my presentation is really present an overview of the nature of the challenge that we're all facing in our different communities, either locally, at a national level, or indeed at an international level. What I'd also like to do is stress, in a fairly brief sense, the limitations of a biomedical preventive approach that in many countries we're still following, and therefore the need to, in terms of reducing inequalities, to adopt a different approach that really embeds public health within a policy framework. And then finally, I would like to highlight some initiatives, international initiatives, which some of you are already involved with, which are linking oral health inequalities together. So, inequalities in health really are at the centre of policy discussion in many places around the world. So this document is from the WHO, which is produced about 5 or 6 years ago, led by Professor Sir Michael Marmot, and that really started the policy drives around disparities and inequalities and what could be done. And in this presentation, what I want to do is really link in the oral health agenda into that broader agenda. And as John mentioned, for the last 25 years, I've been within an epidemiology and public health department, and we're a small group of dentists who are embedded within the broader public health agenda. And I suppose the big message is that epidemiologists from a dental background have an enormous role to play within the broader public health agenda. So we need to be proud and out with that. So if we think of inequalities in oral health, we need to look at the evidence, and many people in this room, and we'll hear the speakers coming up soon, we've got very strong evidence internationally on the nature of inequalities in oral health by different conditions and different populations. But John Greenspan's already mentioned this notion of the gradient in oral health. So we're not just talking about poor people having worse oral health. We're talking about the whole nature of our societies where there's a graded relationship between oral diseases and people's socioeconomic position. And that is profoundly important in terms of policy of how we can change that pattern. And I'll demonstrate that in due course. So let's just look at some of the evidence on the relationships between socioeconomic position and oral diseases. And this is a slide just taken from the north of England by people in Sheffield, Tom Dyer and colleagues, that look at the association between deprivation and childhood caries. And all of us in this room know that strong association, that linear association between deprivation and caries. That is a known fact globally. We've now got systematic evidence from systematic reviews. So Murray Thompson published in JDR a few years ago with some colleagues looking at the international evidence on the relationships between socioeconomic position and caries and found a very consistent and strong relationship. That evidence is really very robust. This next slide is a newspaper article from the Times, England, the London Times, and this article is stressing that now, in many policy circles, the issue of obesity and the issue of oral diseases are really the markers of social disadvantage and deprivation. So by looking at people's mouths, you can really almost group them in terms of socioeconomic position in such a clear way. So that marker of oral disease within the broader society is a very powerful message that even journalists working for mainstream journals, newspapers, have picked up. So let's just look at some evidence on examples of oral health inequalities from different levels, and particularly of relevance for us here in terms of global research, looking at international evidence. But firstly, let me show you some evidence from London, where I've been working for the last 30 years. So this is a map of London, and this is just looking at DMF levels for 5-year-old children. And just as in San Francisco, just as in Boston, just as in New York, variation on geographical area is a standard feature. And what we find is in London, in the East End of London, where John Greenspan originally grew up, where Jack the Ripper used to hang out, where there's no association there. That was just purely coincidental. But the East End of London, that's where the highest levels of disease are. Whereas if you go to the west of London, where the royal family live, disease levels are lower. So that variations geographically are very profound, and you would know that. If we look at one area of London, so I live in what's called Islington, which is near the centre of London, and that's a population of about 200,000 people. And in Islington, we have very diverse populations. Now, I think in the US, you tend to be more separated, where, well, not entirely, but certainly in London, we are very mixed up in terms of our streets and our populations. And literally, my street, there are one end of the street, there's social housing that's a bit like this, not quite so bad. And the other end of the street, there are some people living who are lords, literally lords, who are living in very, very big houses in basically the same street. But what we know in London is, in small areas of London, we have huge variations in levels of disease, even within a local area of 200,000 population. So this is a slide looking at DMF for 5-year-old children by primary school. So I'm not quite sure what the US term for primary school is, but for small children, for elementary school. And what we have is a 14-fold difference between the best children's schools, where there's almost no disease, to the ones where the DMF is over 3. So that's in one area, we've got this level of variation. But next, let's look at some examples of inequalities at a national level. And the examples I'm going to use are mostly from the UK, but again, just to illustrate the point with some different data. So this first slide on the national data is from our National Adult Dental Health Survey. So this is looking at subjective measures of oral health in terms of people's occupational levels, degree, education or no education. And what we can see is for all different markers, or 3 different markers of subjective oral health and oral health related quality of life, those people with less qualifications have much higher impacts of disease. So subjective measures are socially patterned in a very consistent way at a national level in the UK. This next slide is a slide from the English Longitudinal Study of Aging. So this is a national survey of older people, a cohort study of older people, and we've managed to embed oral health into different waves of this data. And this data is looking at levels of edentullousness, so no natural teeth, by a whole range of measures of social position, including educational level, occupational level, broken down into different categories, income, and subjective levels of social status. And for all those different measures of socioeconomic position, you can see that graded association, that stepwise association, that the people higher up in the hierarchy have better levels of oral health. Another example, this is Eduardo Barnaby and Aubrey, who did a paper looking at trends in inequality, and this is looking at levels of edentullousness again amongst adults, but looking at different surveys from 1988, 1998, and 2009, and you can see the consistency of that gradient over time. So this is a universal problem that, although levels of disease are improving, oral health is improving, the graded associations remain consistent. And then the last example at national level, this is some data from the N. Haynes American Survey of Adults, and Will Saba, who did his PhD with us in London. What he did was look at levels, in this example, looking at periodontal disease in terms of periodontal depth, looking at by level of education, but the important message is he also looked at cardiovascular health and general health and demonstrated in the American adult population for both oral health and general health subjective measures and periodontitis and ischemic heart disease, you've got that consistent graded associations across outcomes. And that would strongly suggest a commonality of causes and pathways that are creating these graded associations in adult populations. But let's now look at some international evidence, because this is a global summit, a global symposium. So let's look at some evidence of inequalities across countries, again, hopefully of relevance. Now, we all know that oral diseases vary in different countries. And I think Wagner Massenes, who again has been here, perhaps last year was the speaker, has done a lot of work on the global burden of disease study, which is documenting levels of diseases in terms of oral health and others. And this slide just shows you the variations of oral diseases by countries internationally. And it varies considerably. But that's not about inequalities, that's just about variations by country. What we started doing was look at variations of inequality within European countries. So Carol, one of our PhD students, looked at groupings of European countries using a typology, looking at different political and welfare systems. So you look into what's called Anglo-Saxon, Bismarckian, Scandinavian, and Southern countries, and then also include Eastern European countries, to look at levels of oral diseases and inequalities across European countries. And if we firstly show you the variation in levels of disease across these European groups of countries, and in this example is looking again at edentulousness, just as one illustration, and what you can see is that Eastern European countries have much, much worse health than Western Europe. There's enormous differences between Eastern and Western Europe. But you can see that Scandinavian countries tend to have very good levels of disease, and the others broadly similar. But what we were interested in was then exploring the levels of inequalities within these countries to see if there was variations in inequalities within these groups of countries. So what Carol did was look at the relative index of inequality, and in this case, as an example, looking again at edentulousness, and what you see is across those countries, groups of countries, and in this case, again, it's by occupation, in all those groups of countries in Europe, you have this consistent graded associations, which you'd expect. The variations are there, but it's a consistent pattern across Europe. And those of you who have been to Europe, you know, it's an incredibly diverse place from Eastern Europe to Western Europe, North and South. It's a very diverse set of populations and individuals. But what we then did was look at the actual values, calculated the relative index of inequality, and what was most interesting was that Scandinavian countries have the highest levels of inequalities compared to those other European countries. Although their levels of disease are much lower, the relative inequalities within the Scandinavian countries were the highest. And you can see this is the case for no functional dentition, so that's having less than 21 teeth, natural teeth, that the relative index of inequalities values for Scandinavian countries are the highest consistently. So that paradox of a healthy Scandinavian setting, but greater inequality, is one that in European terms is a really sort of interesting dilemma that is causing a lot of debate, both in medicine and now in dentistry. So let's now look at another example of international comparisons. And what we did last year was publish a paper in the BMJ, in the Christmas BMJ, which was a bit of a bonus for us. And what we did was look at inequalities between England and the US. Now, because it was a Christmas British Medical Journal, they have a quirky set of papers. They're all a bit strange. And believe it or not, this is the front cover of the British Medical Journal's Christmas edition. And that is to do with our paper, and this is our paper where it's published. And it was done in a quirky way, but the paper is done hopefully quite well. And what we did was compare inequalities in England using our national English data from the Adult Dental Survey, then also looking at US data from NHANES. Now, we had some problems of comparability because we wanted to make sure the clinical measures were as comparable as possible, and that wasn't particularly easy. And we also looked at some subjective measures. But what we found, unfortunately for the US, but good for us, was that the US consistently favoured worse than England in terms of oral health, in terms of subjective measures, and indeed number of teeth. But perhaps most interestingly, in terms of the relative inequalities issues, again, in the US, the inequalities in oral health outcomes were consistently higher than they were in England. Now, that was an interesting finding. We didn't actually expect it. One of the co-authors is Professor Ikiro Kawachi from Harvard School of Public Health. It was an interesting mix, and we didn't really expect the findings that we got. But what was surprising was the level of press coverage that this paper got. Because a lot of Americans, you laugh at us British people for having such terrible teeth, and our paper was trying to sort of challenge that sort of stereotype. So, of course, the newspapers picked that story up in a big, big way. So this is one example. This is our I can't remember who she is now, who is she? Duchess of Cambridge, who's got nice teeth, but, we've other British people in the media have got pretty bad teeth. Interestingly, the British media then started saying, British dentistry was better than American dentistry, which of course we didn't test. That wasn't the hypothesis. We didn't show evidence on that, but that's what they got excited about. But the biggest achievement of my career so far was in the Sun newspaper, which is the worst, most gutter, horrible paper in the world. We got a headline in the Sun paper, and Brit bad teeth jibe bites the dust, which I thought was quite a nice point. But in seriousness, what we've shown is that you can look internationally at inequalities between countries if you've got comparable data, and it begins to set interesting stories about whether that's caused by the healthcare system, whether that's caused by cultural factors, whether that's caused by poverty and inequalities economically. It raises some very profound and interesting points. So in summary, what I'd like to say from this first part of my lecture is that we have a mountain of evidence around the world, including lots of very good evidence from the US, of that association between socioeconomic position and oral health outcomes, both subjective, clinical, across the life course, in different populations, etc. And perhaps it's time for us to move on from just measuring these inequalities to beginning to understand the causes of these inequalities to inform policies to actually begin to do something tangibly about these. But let's now look at what has been the traditional preventive approach adopted by dental associations, dental professions around the world, including the UK, very much so. Let's look at that preventive approach and see what the evidence for that approach is in terms of reducing disparities and inequalities. Well, if we summarize what the preventive approach that the dental profession globally has tended to adopt, it's generally, in general terms, been very individualistic in focus, looking at high-risk groups, high-risk individuals using different markers of risk. It tends to very clinical focus, mostly using either fluoride or Fischer seeds, but clinical interventions to try and deal with the problem. it's tended to be very top-down and paternalistic in its approach in terms of its delivery. Often it's tried to impart knowledge with the belief that improving knowledge will automatically change behaviours, which will then reduce inequalities. In certain cases, and this still does exist, it uses threats or fear as a way of trying to force people to change behaviours, where the evidence on such things is actually very limited. And in broader terms, it tends to be apolitical in nature. It does not acknowledge the broader context, which I'll demonstrate in a minute, that is causing these patterns to exist. It's intervening in a sense without understanding the broader context. And this slide is an old picture, but any guesses of what date this slide? Well, what's happening in this slide? So it's toothbrushing. Any ideas what the date might be? Date and location? It's 1912 in New York State, apparently. I find this. But what really upset me was when I showed this to some of our postgraduate students, they thought that was my school photograph. So they obviously thought I was 100 years old. But there's 100 years old. And the point of this slide is not to make me feel young, but is that inequalities in oral health in different populations, these types of interventions have been running for at least 100 years, and toothbrushing in schools really isn't the solution to something that is much more embedded and ingrained as a social problem. But let's look at the evidence first of how effective is that traditional preventive model in terms of improving and sustaining better oral health and reducing inequalities. Well, what we have in our field, just like you have in different fields of dentistry, is a whole range of systematic reviews that have reviewed the international published literature to assess the effectiveness of different interventions. And this is just a sum of the studies. Louise Brown from Melbourne in Australia, all the way down to Public Health England. A whole range of reviews have been published that have systematically assessed the evidence on how effective prevention is in terms of actually achieving positive change. And the unfortunate news is, or conclusions is, that it really demonstrates the limitations of this very narrow clinical preventive model in reducing inequalities and disparities. So what the evidence shows is that a lot of those preventive interventions can achieve change, can improve health, can improve both clinical outcomes and subjective measures. The problem is often they're not sustained in the long term, they diminish. The other problem is that they do not reduce inequalities. So rather than reducing inequalities, they actually can increase inequalities, as I will show. Another problem is the cost of these interventions, which they rely heavily on professional input, and that is expensive. They can be duplication of effort, different professionals giving different messages to the same populations, and they become overcome with constant messaging. And that duplication of effort and ultimately public resistance is a persistent and common problem. So what is now recognized, many of you will know about the inverse care law, but we've now got the inverse prevention law, which shows that interventions may improve health at a general population level, but what will happen is that they will widen inequalities, because the groups who will benefit the most from the intervention are those that are the healthier, those with the resources, those that are in a better position will benefit greater than those with higher levels of need. And a good example to illustrate this comes from a study from Lona School in Edinburgh. It's quite an old study now, it's almost 20 years old. But what she showed was that levels of bleeding and levels of plaque, if you looked at deprived schools and non-deprived schools, 6 months after the intervention, what actually happened was that the inequalities between increased as a consequence of the intervention. So rather than reducing disparities between deprived and non-deprived schools, what happened, the intervention increased significantly the differences across the groups. So for us, we need to be very careful and mindful. Are our interventions really reducing inequalities, or is there a risk that they actually may increase inequalities? So in summary, what I would stress is that we know the dominant preventive model may be effective for middle-class, affluent populations attending dentists, but that program, that approach, is not effective in terms of reducing inequalities. What we need is a different type of approach that broadens from being too clinical and too narrow to one that is more of a public health agenda that looks at policies, settings, and looks at more sustainable changes. So let's now look at some examples to illustrate this broader public health agenda that is more likely to have an effect on reducing inequalities. Well, to do that, what we firstly must understand and document and acknowledge is the underlying causes of the social gradients in your country and in my country. What causes these universal stepwise gradients in our health? We are now in a School of Nursing, but we've just been in a School of Dentistry. Most of us who've been trained in a biomedical model concentrate our education and training looking at such levels as plaque levels, hygiene, diet, tobacco, alcohol. These are important determinants of oral diseases. We know they're important. However, the evidence, and this is a paper by John Spencer and Sanders, a paper by us in London, when we analyse the contribution of behaviours, of lifestyles, they do not explain inequalities and disparities. Even if you adjust for all the different behaviours, you still get these systematic inequalities and gradients. So our interventions must move beyond a behavioural approach to one that looks at a broader environmental and policy arena. So what we're talking here really is a paradigm shift from a biological, biomedical approach of etiology to one that moves beyond a lifestyle approach to one that what we now call a social determinants agenda that is really a truly holistic approach to understanding disease pathways, etiological mechanisms, and intervention points for policy. So very briefly, and hopefully most of you are familiar with the social determinants model, but if we briefly show a social determinants model and its application to oral health, that will hopefully demonstrate the point. So one of the most common slides in all public health courses is the dull green and whitehead rainbow diagram to illustrate the range of individual, social, community, societal factors that influence and determine disease patterns in populations and ultimately levels of disparities. So these types of models have been heavily influential in terms of policy developments and interventions. And essentially, it's about understanding the wider influences that socially pattern the lifestyles that then determine the different levels of disease, including oral diseases, in our patients and our populations. Aubrey, myself, and others have created a range of different social determinants models for oral disease and oral health inequalities, and this is just one illustration that tries to look at the socioeconomic context, socioeconomic position, and then highlight the psychosocial factors, the behavioural factors, the health services factors that ultimately determine the gradients. If our interventions only focus on this element, they are missing out the larger drivers of these patterns in our communities. So that social determinants model has a profound influence on interventions to improve health and reduce disparities and inequalities. And what we now have is quite good evidence on the nature of policies that have been used not so much in oral health, but more in public health and general health to reduce inequalities. So let me just share you some of the evidence on effective policies to reduce inequalities. So these are from reviews from the WHO, from Claire Bamborough in Durham, and what the evidence suggests in the public health literature to reduce disparities at a community level. What we need are structural changes in the environment to create a supportive environment for our populations. We need legislation and regulation to improve the settings and environments in which people live and work. We need fiscal policies to drive healthier behaviours and healthier practice. We need to focus on young people, early life and in the good early life start. So the first 5 years are the key point for intervention in terms of creating a foundation for good health. We need community action. We need improving accessibility to a range of services, and we need prioritization of disadvantaged groups within different systems. The evidence suggests these types of policies are the ones that are most likely to be beneficial for disparities reduction. The interventions that are ineffective at reducing inequalities or may increase inequalities include programs that only use information, providing information to the public. The danger is that those mass media programs actually just increase inequalities. Relying on written materials only, again, the danger of increasing inequalities. Campaigns that are reliant on people taking the initiative to opt in, again, have that danger. And then lastly, these health education campaigns that are broadly focused without being targeted, again, the evidence is that they can increase inequalities. So I suppose for those of us working in communities, we need to think, do any of these types of interventions, are we responsible for running these? Because ultimately what we're trying to do is what's called proportional universalism. We're trying to design interventions that are trying to level up the gradients. So what we need is, rather than only focusing on the disadvantaged tail, the high-risk groups, we need a graded type of intervention that can change the whole balance and nature of those gradients. And those interventions need to work at a clinical level. So we need to help strengthen individuals. So that's where individual clinicians in the dental office have an important role. We need to look at strengthening communities. So that's where our public health colleagues and community workers have an important role. And then lastly, we need to look at the broader societal level, where our politicians, our policymakers have their roles in terms of influencing and creating a more supportive environment. So let's just finish off with some examples to illustrate how in dentistry, in oral health, how we have a different role to play in terms of reducing inequalities at both a clinical, a dental association level, and indeed national level. So at a clinical level, the UCL Institute for Health Equity 2 or 3 years ago had a meeting with the medical associations around the world, and what they produced was a document that summarizes how medical practitioners, how medical clinicians can become involved in improving and promoting greater levels of equity. And what we did is we translated that document essentially for dentistry. So David Williams, Aubrey, and myself published a paper in the British Dental Journal which basically tried to analyse and summarise what clinical dental staff can do to reduce inequalities within their patient populations. And in summary, some of the issues that they can do at a local level within a clinical dental office is understand the needs of their local populations more. So rather than have that inward-looking focus, begin to look outwards. And this morning we had some very interesting discussions from various colleagues about how different projects run in this university and elsewhere of dental staff engaging more broadly with the community. That's a very important step. We also need to look at the professional skills that the dental professionals are trained in, and such things as communication, partnership working, working across sectors. People need to be trained in the skills needed to do that effectively. We've mentioned the importance of focusing on early life, on the first 5 years, so clinicians can particularly prioritise mothers and young children in terms of their preventive activities. We can look at ensuring equity of access and levels of treatment. And it was very encouraging to hear Ben mentioning that your mission statement for this whole university is about equity and fairness in terms of provision. We need to use a team approach. So with equity, often working with other members of the team is a fundamental issue. Now that can be a challenge, it can be difficult, but a team approach is very important. Dentists need to begin to start working across sectors. So rather than only working in the dental office, they need to begin to make connections with other important local agencies and sectors. And one very interesting point is the dentist, as an employer of local people, has a big role to play in helping local people become trained, develop careers and move forwards. And there's some good examples in the literature of the dentist as a local employer having a positive role in that economic element. Next example to look at is the role of dental associations. And in the last few years, I've been involved with various things in the UK, in Japan, and I'm beginning to think that dental associations are more and more interested in issues such as this. And the FDI are one organisation, and this is a publication they've produced looking at advocacy and the role of dental associations in promoting broader changes in society. And I was very pleased to see this morning this campaign around tobacco costs in California being supported by the Californian Dental Association. So dental associations as a professional voice have an important role to play. So they can, and in some cases have done this, and a good example is the Swedish Dental Association, where the Dental Association is an advocate for improvements in inequalities, including oral health inequalities, also in terms of training and capacity, and this issue of partnership links, the Dental Associations linking across other agencies. But then finally, let's look at what would be the public health approach to reduce disparities and inequalities. Well, in terms of public health action, some of the core criteria that need to be embedded within public health programs include the issue of how we reduce inequalities and promote equity. We need to think about empowering our participants. We need to think about having a broad, holistic focus, embedding oral health within that broader common risk agenda. And we need this issue of multi-strategy approaches that one intervention alone will not reduce disparities in a sustainable way. So over 40 years ago, John McKinley, and I think it may have even been in California, developed the upstream-downstream analogy. And in dentistry and oral health, that is still such a strong message that to achieve reduction in inequalities, we need interventions across the spectrum of that upstream-downstream model. If we only look at downstream, we're not going to solve the problem in terms of inequalities. And a perfect example to illustrate this is the successes that have been achieved in tobacco control. And this slide is Dr. Margaret Chan, who's the WHO director, and she is a very, very strong global advocate for tobacco control. And across the world, and in the US, you probably were one of the countries that really led this development, tobacco overall rates have reduced significantly in many, many countries. Not everywhere. In some low-income countries, they're going up. But in most developed and middle-income countries, tobacco rates have gone down. But the evidence is, if you look at evaluating the different types of policies and actions that have caused that reduction, this is a paper from in PLOS Medicine that looking at across a 10-year period in a whole range of countries, what they showed was that let me just do it quickly, in the countries that had smoking cessation services, that the number of smokers quitting and number of lives saved from that interventions were significant. They were, I think, 700,000 and 300,000 lives saved. You know, that's a big saving in terms of action by smoking cessation. However, if you look at the effects of raising taxes on tobacco, the number of smokers that quit was over 7 million, 10 times more were because of the tobacco changes in terms of cost rather than advice, and in terms of number of lives saved, 3.5 million people's lives saved because of taxation policies. So the point with the tobacco control agenda is that the upstream actions are the ones of maximum benefits at population level. So let's finish off by looking at another challenge we have in oral health is reducing sugars consumption and that challenge of reducing sugar in our population. So we've got new guidance from WHO, international guidance on reducing sugars, and I don't know the exact figures in the US, but if we look at the UK, our sugars consumption is double what the recommended 5% of sugar from energy should be across the population. In the UK, it's at least 12, 15%, double what it should be. I suspect in the US, it's probably very similar, if not even a bit higher. So how can we reduce sugars consumption that are now recognized as both a major risk for caries, but also for diabetes, metabolic conditions, etc., etc.? Well, what we need is this upstream-downstream approach applied to food policy. So we need action to reduce production quotas, subsidies, minimum price trade mechanisms. Now, that's a very upstream level that requires politicians to act and reduce subsidies to farmers, etc. We need to work with industry around reformulation. So in the UK, we've reduced our salt levels by about 40% because the food companies have removed salt from bread, from a whole range of products, and the salt levels of consumption has gone down significantly. We also need to look at taxation on sugars. Now, it'll be interesting to have a discussion in a minute about taxation and sugar tax in California, because I think you've had some debates about this, but that's another major way forward. We need to look at marketing restrictions, advertising, promotion, etc., of sugar is still largely unregulated. And then lastly, we need better information for clients, for consumers, in terms of products, etc., etc. But the one success we've had recently in the UK is, in the last 2 weeks, our government has just announced a 20% tax on sugar for sugar-sweetened beverages, which was a huge shock. None of us expected it. It's a highly political decision based on politics rather than public health. But the fact is, even with a Conservative administration, this policy is going to be a national introduction in a few weeks' time. So my last point is, I would argue that inequalities in oral health are a global issue. And last year, we launched a new network, the Oral Health Inequalities Research and Policy Network, and Beth was at that meeting. So we had a meeting in London, which over 250 people came from, I think, 40 countries to begin to start the debates about how we can share information around inequalities in oral health and reduce this perennial, persistent problem. So we had, one of our speakers was Michael Marmot. We had quite a nice range of speakers. But the point is that this is a platform, a network across 20 different universities, including the University of Pittsburgh, by the way, of looking at the research and the policy issues of how we can tackle this problem. So I would really like to talk about how we can engage with you here in San Francisco around this issue and the potential synergy around that. What we produced was a monograph. So this document's available online, which summarizes the evidence on the nature of inequalities, the social determinants, and the action. And we published a paper in JDR a few weeks ago, which launched the London Charter on Oral Health Inequalities, again as a summary document to try and begin to engage across sectors. So my 40 minutes is just coming to an end. So in conclusion, what I'd like to do is say that there's a global challenge that exists of reducing these inequalities in oral health. And in this room, with your skills, with your expertise, with your contacts, we together can begin to really make a difference on this. We do, however, need to recognize the limitations of this very traditional clinical approach, and we need to use the broader public health agenda. And that international collaboration, I think, is fundamental. So I think, your symposium series here, our network in London, together, there could be very good links. And my final plug would be, in London, each year, we have a summer school on social determinants of health and inequalities. And this year, it's in July. And at that summer school, we have various speakers, including Michael Marmot, and each year there's a collection of dentists come to it, and normally they really enjoy it. So if you're interested in coming to London, get in touch and I can give you more details. And I'd just like to thank you very much for your attention, and we can have a discussion afterwards. Thank you.
Yeah, so to tax in the UK, so how visible is dentistry in being part of that collaborative model of addressing common risk factors?
People laughed at us if we were interested in sugar. I'm serious. People thought it was a minor peripheral issue. Now you have professors of cardiovascular health, you have all the mainstream Royal Colleges, paediatricians, etc. now talk about sugar. So I think our agenda is, through advocacy, using the common risk factor approach, is we may not get the credit for it, we may not get the gold star for it, but if we can embed our message within that broader agenda, the politicians and policymakers take note. So I think that's a fundamental challenge. How do we do that in a really proactive way? And I think we just have to keep working at it and keep giving evidence. And I think now what we do have is much better evidence of the public health importance of oral diseases in terms of educational achievement, in terms of employment opportunities, etc., etc. So I'm fairly optimistic now. We're much more mainstream because of that quality of evidence.
Let's thank Dr. Watt for his presentation.
Good afternoon. I have the honor of introducing our next distinguished guest speaker, Dr. Gloria Mejia. Dr. Mejia is Assistant Professor of Epidemiology in the School of Dental Medicine at East Carolina University. She is a dentist, received her dental degree from Universidad de Antioquia in Colombia, with a master's degree in public health from Florida International University and a PhD in epidemiology from University of North Carolina, Chapel Hill. Dr. Mejia began her research career at the Australian Research Centre for Population Oral Health at the University of Adelaide. Then she spent a couple of years here at UCSF as assistant professor in residence in 2008, where I had the pleasure of working alongside her before she returned back to the University of Adelaide. Dr. Mejia has extensive experience in population health surveys and applying novel methodological approaches to study oral health disparities. Her research focuses on disparities in oral health and oral health care of children and underserved groups. Dr. Mejia's main line of research is in population oral health, especially as it involves close collaboration with communities and establishing global partnerships. She has served as scientific reviewer for funding agencies and journals and published in well-known peer-reviewed journals and presented in local, national, and international conferences. Today, Dr. Mejia will be presenting an overview of research related to migrant populations around the world, framed through a social determinants perspective, including challenges and opportunities to engage with immigrant communities as participants and partners in addressing equity in oral health. So please join me in giving a warm welcome to someone I've looked up to since I've met her during her time here at the Can Do Center, Dr. Gloria Mejia.
Thank you very much for that introduction. And thank you for the invitation to be here. I am very pleased to come back to San Francisco and be here at UCSF. So I will be presenting on migration and oral health, and after some general background on global migration, the presentation will focus on two main components. So one is the global measurements component, and it will be largely based on past analyses that I've done from work on my dissertation, my postdoc, and more recent collaborations with some of my colleagues from overseas. And during the second part, I'll present a bit about my current research, and it's in partnership with a community organization that promotes the active participation of Latino immigrants and their new communities in Eastern North Carolina. So here we are seeing the lifetime path of one person. My own. But there are 243.7 million migrants in the world today. So all of a sudden, this one migration pattern becomes this beautiful rainbow. International migrants comprise 3.3% of the world's population. This number of migrants would constitute the fifth most populous country in the world today. On this slide, we can see the steady rise of migrant populations since the 1960s. And listed on screen are also the countries with major net immigration and migration rates. The stock of international migrants remains concentrated in relatively a few countries. And so, for example, the United States hosts 20% of the migrant population worldwide. So now let's set up a framework, which is great following the previous talk, to be able to examine migration and oral health. So we have a country of origin and we have a host country. And each one of those countries is influenced by their own unique set of demographic, societal, economic, and political factors. Quite simply, this is the process of migration. And we see that the social determinants in the country of origin influence or initiate that migration process. So emigration is socially determined. But within the host country, migration itself or immigration becomes a social determinant of health. So these social determinants will influence the health outcomes of their people. So while many immigrants do prosper in their countries, their new host countries, some of them will undergo exploitation, maybe discrimination, and that will negatively affect their health. Migrants also have health problems that are uncommon or poorly understood in their new countries of residence. And in addition, socioeconomic and legal barriers impede access to health services. And in cases where migrants might have access to health services, sometimes those services aren't linguistically appropriate or culturally relevant, and so that poses some additional problems to them. So a commonly recognized factor is that of migrant children who, despite being nationals of the host country, face healthcare barriers, particularly if their parents are migrants in an irregular situation. So let's think of immunizations, for example. If children are unable to have vaccinations or have to postpone their vaccinations, then this could cause long-term effects not only on their own health, but also of others. There are only a few cases where portable health care benefits exist between countries, and one example of those would be between the Moroccan and German governments. Brazil, Spain, and Portugal are examples of countries that have adopted a policy of equal access to health care coverage for all migrants, irrespective of their legal status. But an exceptional case is that of Thailand, in which immigrants, upon arrival, are able to access the country's universal health care system, even those that are undocumented. Okay, so of course the social determinants in the country of origin are also affecting their own population's health outcome, but that's not the whole picture, because migration not only affects the health outcomes of the host country, but quite importantly affects the health outcomes of the countries of origin. And so we'll talk a little bit more about that aspect in the next couple of slides. So let's continue to think about the chains of migration. So these can be as diverse as all possible combinations of countries across the world. And they will undoubtedly affect perceptions, the right to access service, and population health outcomes. Immigration histories vary substantially among individuals and groups and are influenced by factors such as treaties between governments, for example. They could be influenced by war. They could be influenced by the country's economy, and of course, individual traits and own financial hardships. So despite the challenge, comparisons between migrant populations and those born in the host country are a common theme in oral health research. So for example, a study that was comparing a Swedish-born population to those that were residents of Sweden, but born in Poland, in Chile, in Turkey, and Iran, the odds ratios that adjusted for socioeconomic conditions varied from 6.5 to 2-something amongst these countries. So, for example, among Iranians, when regarding difficulty chewing, they had an odds ratio of about 6, whereas among the Polish residents, they had an odds ratio of about 3. Not receiving dental treatment in the previous 2 years ranged from 1.9 for those born in Poland to 3 times the odds for those that were born in Chile. So we see how migrants within the same country, just the country of origin and their own histories, will affect outcomes. In an Australian study, for example, Greek participants most often cited as barriers to accessing healthcare services time that they had to spend in the dental offices and the waiting lists, whereas the Italian migrants in the same study, they cited that it was cost, one of the major barriers, and language was also a major barrier that they identified. Mikami and colleagues reported on a study between British expats and compared them to Japanese. So it was between children of British parents and Japanese parents in Japan. And part of the discussion on why the British children fared better was related to the oral health care system in the UK and also the lack of fluoride treatments, let's say, or fluoridated toothpaste and such for the people in Japan. So the Japanese parents did, however, take their children more frequently to the dentist than did the British. But the British reported more visits for preventive care. And although the British had a sweeter diet, than the Japanese children, they did have fewer decayed teeth, so something else is going on there. Now, we all know that people that migrate come to the host countries under different circumstances, and so there's different migration categories. And depending on that migration category, there will be additional challenges. So most frequently commented on is that of the irregular or undocumented migrants, but there are also skilled migrants, there are students, there are victims of forced migration, there's refugees, asylum seekers, and unfortunately there's smuggled people and trafficked people, and we know very little of these populations precisely because of their clandestine nature. An example of research by migrant category was done here in the United States, and very recently, which examined child oral health care access by their parents' immigration status. And parents were categorized as being legalized, refugees, temporary residents, mixed status, or undocumented. And the report found that dental care was most common, delayed dental care was most common among children of refugee parents. Okay, so immigrants in general, they tend to settle within already established ethnic-specific communities. And in these communities, they are able to maintain close ties with their culture, their language, their traditions. And so although this cultural coherence helps maintain that ethnic identity and preserve some of those values, one concern is that it might impact the utilization of healthcare services. So for example, a metasynthesis on selected literature of elderly Chinese immigrants revealed a dynamic interplay between the traditional Chinese beliefs about oral health, their immigration, and structural factors that mediated access to Western dentistry. A related research challenge refers to measurement. So the cultural equivalence and the validity of health-related measures and research methods using instruments and constructs designed in one population to try and understand another population can be reasonably questioned. And there was a whole special issue in 2006 of medical care that was trying to look at this issue specifically. Another factor that has been questioned is that of the healthy migrant effect. So Ann Sanders examined the presence of Latino advantage on oral health-related quality of life, and she found that first-generation Latinos in the United States experienced better outcome than non-Latino whites. The advantage of these foreign-born could not be attributed to the healthy migrant effect, however, because when she did the comparison of immigrants of non-Latino origin, that advantage did not hold. So one of the plausible explanations was maybe that of culture. Now, Salmon bias refers to the return of migrants to their countries of origin, and it's more common when they become older. So they retire and they go back home. So unhealthy out-migration relates to that healthy immigration, particularly with regard to mortality rates. So there could be some biases that the data is showing there. More concerning, however, are the structural effects of return migration on the economy and the healthcare system of the country of origin. So we do have that the healthy and the young leave the country, and then they return when they are no longer able to work and when they need to use the healthcare system much more. A similar concern is that of the brain drain. So particularly for countries where the capacity to reinvest in the educational system is limited, losing health professionals will have a great impact on that country's ability to treat their own people. And moreover, sometimes these professionals migrate, and in their new countries, they're not able to use all that knowledge that they gained in their original countries. Also, when the migrating health professionals are trained in a country of origin that's under a nationally subsidized educational system, then low and middle income countries are actually subsidizing or are supporting the health systems of the high income countries. For example, the doctors trained in Ghana during the 1980s, 60% of them emigrated overseas. So improved surveillance of the migrant dentist workforce has been strongly advocated in order to strengthen global policies around these migration efforts. Okay, so most of the research on migrant populations falls roughly under one of these categories. The migrant studies compare the health indicators of immigrants that reside in the host country with immigrants that are residents in the country of origin. Now, this type of study has several limitations because immigrants generally do not represent the general population of their country of origin. And it really does not account for the differences and the types of migration, which I spoke about previously. So it's unlikely, for example, that voluntary migrants, it is likely that they will be healthier than those that are forced to migrate. Population surveys are quite common for studying migration and health, and surveys have the disadvantage of the lowering response rates. We see that each time it's lower and lower. And for migrants, an additional concern is regarding this representativeness of the sample is language. So participation is less likely when there is a language barrier, and surveys cannot account for or provide the option of having the information available in multiple languages. I mean, some can, but for the most part, that's difficult to come across. Then there's community studies, and these generally occur within immigrant communities and generally do not entail comparisons with other populations. And in the next section, I am going to present examples of my own research that fall into these three categories. Now, we also have generational studies, and those are the ones that compare first immigration migrants, second immigration migrants, and so forth. And we have longitudinal studies on migrants. In the United States and in Canada, there's a longitudinal survey of immigrants. In Australia and Canada. In the United States, they have the children of immigrants, longitudinal survey. And then finally, there's those that combine multiple methods. So now in this section, I want to present a bit of my own research. This study was a product of collaboration between the University of Montreal in Canada and the University of Talca in Chile. Not being from either of those places, I was invited to contribute to this study because of the collaborations that I had long established with researchers from Talca. So the study aimed to look at the use of dental health services in children that were living in Talca and that were living in Montreal between 2009 and 2011. The samples were selected to have similar distributions with regard to sex, family, income, and parental education. So although both countries have similar oral health care systems and policies that favor children, it is evident from the graph that I'm showing there that the children that are in Talca are using services much less than the immigrant children in Canada. And this was a surprise to us because we expected that the children in Talca would be able to, or their parents would be able to navigate their own healthcare system much better. Further analyses that we did then indicated that parental education was a key factor in the use of oral healthcare services for both of those countries. And we found that in Talca, but not in Montreal, parental perception of child's general health was associated with dental services. So general health associated with dental. Now, we didn't examine differences in the types of patterns of migration, and our sample size was relatively small. So now from Chile and Canada, we're going to move to Australia. And so in here, this is the data from the 2004-2006 National Survey of Adult Oral Health. And we used a global measure of oral health, which is known to be associated with functional impairment, discomfort, clinical measures. And the original scale was dichotomized to indicate the proportion of people who perceive their oral health as fair or poor. So the Australian-born population had a smaller proportion of people who self-perceived their dental health as fair or poor when compared to the foreign-born. There were no differences really between the overseas-born who spoke primarily English and the overseas-born who spoke a language different than English. Now, in this slide, despite those very wide confidence intervals, you can see a general pattern. And lower income groups report progressively greater proportions of people self-rating their dental health as fair or poor, and now we know that this is similar to the data from the UK. And as indicated by the estimated prevalence ratios here, we found that migrant status groups remained, the differences between the migrant status groups did remain significant in those multivariable models. And compared to the Australian-born, well, the migrants were more likely to self-rate their oral health as fair or poor. Now, for dental visiting, we use three variables to determine the usual patterns of visiting. So, time since last visit is a key indicator of access to dental care. The usual reason for visiting a dentist reflects that intent and helps to characterize the long-term patterns of visiting. And regularly visiting the same dentist refers to an ongoing relationship with the provider and sort of that dental home that we talk about frequently. Financial barriers reduce the likelihood of dental attendance. And can influence the timeliness and the comprehensiveness of care. And so we use two variables here to look at financial barriers. Avoidance and delay in dental visiting represents a barrier prior to seeking care, whereas foregoing dental care due to cost represents a barrier in getting the treatment that is recommended or that is needed. And so our results here point to really very little differences between the migrants and the Australian-born populations. So the three groups were equally likely to have visited a dentist within the last 2 years, report usually visiting for a checkup, having a regular dentist, and reporting that cost prevented treatment. There were some differences, however, in the percentage of people who delayed or avoid seeking dental care, and particularly for the overseas-born population whose main language was English, which again is sort of an odd finding there compared to the Australian-born. Okay, so within the United States, and this data also used the NHANES, so the National Health and Nutrition Examination Survey from 2011 to 2012, and we wanted to look at differences between oral health and oral health care between the foreign-born and the US-born. So as in Australia, a greater proportion of the foreign-born population in the United States report fair or poor oral health. On average, it's about a 10-point difference between the two groups. And when looking across the income groups, the highest income category shows the least difference and the middle income category shows the greatest difference. But what is really most notable here as well is that gradient, so that social gradient. And we see that for both groups, for the foreign-born and for the native-born. Using that same NHANES data, then we moved on to look at dental visiting. And a greater proportion of US-born populations had a dental visit in the previous year, 66% compared to 54% among the foreign-born. We also see a gradient for dental visiting being a little bit less evident for the foreign-born population because of that bit there between the two lowest income groups. And although I didn't show confidence intervals here, the estimates were very imprecise, and so we really can't eliminate the possibility that there could be some random variability there that would report those differences. But a study by Wilson and colleagues, which was published just last month, used data from the Medical Expenditure Panel Survey, so MEPS, from 2008 to 2012. And they wanted to examine dental care utilization between US-born citizens, naturalized citizens, and non-citizens 18 years of age or older. And they reported that the foreign-born group was significantly less likely to report a dental visit between the 12 months. And this was between 23 and 40% compared to 44% of the US-born population. They also reported a smaller proportion of the two foreign groups having comprehensive dental examinations, but the non-citizens were more likely to receive extractions than the citizens. So I'm going to show you now data from my dissertation, which although is much older than the Wilson study, you'll see how the two results or the two studies actually complement each other nicely. So I linked the data from 1995 through 1998 from the National Health Interview Survey to data with the 1996 through 1999 Medical Expenditure Panel Survey. The National Interview Health Survey is a cross-sectional study, but it serves as a sampling frame for the MEPS study. So we're able to link those. My study was limited to Hispanic or Latino minors. And what you're seeing on this slide is the outcome of interest, which is the type of oral health care that was received. So the screening-only category originated from the MEPS variables that I'm showing there on the slide. And the early prevention category, we combined prophies, fluoride treatment, sealant applications. The remaining MEPS procedures, so all of them, we combined into any type of treatment. And then our fourth category was not visiting the dentist in the previous 2 years. The statistical analysis was guided by the directed acyclic graph that you're seeing on screen. And the variables in blue that I've highlighted there were the ones that we actually had available to do the analysis. The black ones we didn't have. As another side note, I included Puerto Ricans as being US born. And this is contrary to what the survey had originally done, which considers them as being foreign born. But I included them as a group of native born. So with the results here, we see that being foreign born or US born is associated with the type of dental care that is received. US-born youth have a higher odds of receiving screening, early prevention, and all types of treatment than the foreign-born. And despite some overlapping categories there is also indication that the effective place is stronger for any treatment when we compare it to the other two categories, and for early prevention when we compare it to the screening. Now, this slide here is indicating a crude relationship, so I'm not adjusting for anything here, and it's estimated by prevalence odds ratios, 95% confidence intervals, between being foreign-born, which is used as the referent, and US-born and the type of care received among the Hispanic subgroups. So now I'm trying to look at the different subgroups. And I'd like to call your attention in particular to the Mexican group. And for all types of care, being born in the United States has a noticeably favorable odds than being born outside of the United States. So to summarize what I've presented thus far, migrants differ by their country of origin and their migration history and their status in their host countries. Research should account for this heterogeneity when possible, and by doing that, we can avoid common things such as ethnic glossing. Studies generally coincide on indicating that the migrant use of health care is less frequent than the native-born populations, although the Australian data that I presented actually showed similarities in the dental visiting patterns despite those differences in the self-rated oral health. Likewise, a greater proportion of Chilean immigrants in Montreal had more dental visits than the Chileans in Chile. Based on the analysis of Hispanics in the United States, so the last one that I presented, being foreign-born or US-born is associated with the type of care that is received, and the more recent data confirms that foreign-born populations are less prone to have examination visits, but they looked at specific treatments, not like I did, any type of treatment. And within those specific treatments, we see that the foreign-born are more likely to receive the sort of end-stage treatment of extractions. Most researchers highlight the need for culturally appropriate or migrant-sensitive healthcare if disparities are to be reduced, and I agree with this idea of cultural relevance and cultural appropriateness, but we know that disparities are not going to be solved through dental treatment alone. And that was appropriately highlighted in the previous slide, in the previous presentation. So with regard to migration in particular, social and economic determinants of countries of origin and destination, including bilateral government policies, will drive global actions. However, policy reforms depend on political decisions from agencies outside the health sector. And these might be policies around migration or around labor. And so all those things need to be considered. The General Assembly of the United Nations highlighted that, leveraged by the right policies, migrant communities can significantly contribute to the development in both origin and destination countries. And we see this already through the remittances, for example, a lot of exchange there. Trade, investment, creation of enterprises, transfer of technology, skills, knowledge. The Migration Policy Institute recently posted an article discussing the decline of Mexican immigration to the United States, and among other factors, it attributed to the weakened job opportunities in the United States for these immigrant populations and the improvement in the Mexican economy. So we see how other factors outside of health are actually influencing things. Mexico's comprehensive healthcare strategy for migrants aims to promote healthcare access for Mexicans that are living outside of Mexico. Sri Lanka's Bureau of Foreign Employment offers services to Sri Lankans willing to work abroad, and that includes recruitment, advice on living and working conditions, and support upon returning to Sri Lanka. The Sahana Insurance Scheme offers medical insurance, funeral expenses, and disability insurance to migrants. And although with limited benefits, the Philippines Social Health Insurance Scheme provides outbound migrants with portable insurance. Okay, so now I'm going to move on to the final part of the presentation, local actions. And I'll start with East Carolina University. So since 1915, the motto of East Carolina University has been to serve. And according to the university's strategic plan, the long-range outcomes of public service include students with a sense of connection to their communities, empowered communities who collaborate with the university in addressing and resolving problems, and interprofessional networks of scholars focused on community issues. In line with academic institutions, the mission of ECU is operationalized through education, research, and service, and the latter is expressed as leadership and partnership. So community engagement is present across all areas, and because of the commitment of faculty, staff, students to the scholarship of engagement, East Carolina University was twice honored with the Carnegie Foundation of Community Engagement Classification, and this is the highest honor in community engagement. The Scholarship of Engagement describes collaboration between institutions of higher education and their larger communities at the local, state, regional, national, international level. It is a mutually beneficial exchange of knowledge and resources in the context of partnership and reciprocity to enrich research activity, all types of scholarly activity, and engagement enhances the curriculum, the teaching, learning at the university. It supports the academic endeavor by preparing educated and engaged citizens. It strengthens democratic values and civic responsibility. So the East Carolina University Engagement and Outreach Scholars Academy, EOSA, develops students and faculty to plan and conduct scholarship of engagement. The Academy's purpose is to increase participants' knowledge, motivation, and capacity to secure research funding and conduct scholarly engagement. The academies allow key external stakeholders to partner with university faculty and improve the quality of life for the population of Eastern North Carolina. So the academies include the faculty EOSA, the graduate student EOSA, and the East Carolina Scholars EOSA, which are undergraduate students. And after a peer selection process, the scholars attend a series of workshops, complete a research proposal, and implement the research with a community partner. So my community partner is the Association of Mexicans in North Carolina, AMEXCAN, And as the immigrant population grows and becomes more diverse, so does Amexcan. So the organization has really become the primary resource center, or sort of a home for Latinos, regardless of their country of origin, that move to East Carolina. The population that Amexcan serves are working poor families that lack access to healthcare, social, educational, and other services. The organization strives to provide Latinos with certain services that they don't have, and to create a strong regional identity. Also, it helps them advocate issues ranging from poverty to basic human rights to health. And currently, the organization reports serving over 90,000 people. So the mission of Amexcan is to promote the active participation of Mexicans and Latinos in their new communities and encourage the appreciation, understanding, and prosperity of the Mexican and Latino community. Its mission is achieved through events, advocacy, service initiatives that focus on 5 key objectives: cultural, educational, leadership, health, and advocacy. Amexcan leads programs to increase the community's knowledge of, access to, and ability to utilize existing social, physical, and mental health services, as well as educational opportunities and housing services. Among its initiatives, I want to highlight the binational program with Mexico and the Promotoras model. The binational program began in the spring of 2014, so it's relatively new, with the aim of developing a framework for global collaborative partnerships between sending and receiving communities. The framework uses the community-based participatory research approach on both sides as a mirror image to engage and to protect communities. The program is led by Juvencio Rocha Peralta, who is the director of Amexcan, and Dr. Roberta Bellamy, who's the binational research and grant director for Amexcan, and their counterparts in Veracruz, Mexico. The partnership began with the medical school at the University of Veracruz and a community organization in Veracruz, very similar to Amexcan, and of course the community. However, the development of engaged collaborative partnerships between Veracruz and Greenville requires expansive work across the border. So discussions with other partners and stakeholders include the Rotary Club, the Lions Club, the State of Veracruz, the Ministry of Foreign Affairs in Mexico, and in the US, the Mexican Consulate. And all these layers are placed so to protect the communities both in Veracruz and in Greenville. The framework's initial focus has been on health, and it's centered on a bio-psycho-spiritual model. The first research project is on HIV, and it hits ground during the second half of 2016, so we're excited about that. But the health model is now crossing fields, and it's being expanded into education as well. The promotoras and promotores are community members, women and men. They're generally volunteers that foster change within their communities. Amexcan promotoras do not follow the model that is commonly used in other organizations, in which the role is limited to health issues. In the model that Amexcan follows, the promotoras also engage in cultural, educational, leadership, and advocacy activities in line with Amexcan's 5 priority areas. They work to create better economic, health, and social outcomes, and they become voices for their communities on all of these priority areas. The model also allows for the creation of special interests groups. And within those special interest groups, promotoras can concentrate on issues that are of heightened importance for certain population groups. And so some I've listed there on slide, but we have, for example, domestic violence promotoras, and we have social justice promotoras. The promotoras receive continued education through weekly meetings that include workshops, guest lectures, and these are generally led by faculty from East Carolina University and other partners that work with Amexcan and engaged scholarship. For example, our dental students quite frequently attend promotoras meetings and talk to them about oral health issues. So the Promotora Group started in 2009 as a community health advisors project in collaboration with the university, with ECU. The program started in Pitt County, where Greenville is centered, and that's shown on black there on the screen. And as funding has become available and the replication of the program has been used by other partners, we've been able to extend to 6 other countries. The program began with only 6 participants, and currently, only in Pitt County, we have over 50 active members. AMICSCAN holds 10 important events during the year, which range from community-wide celebrations to leadership and research conferences. For example, El Día del Niño embeds Latino children in their culture and fosters their appreciation of Latino customs and traditions. In March, Latino women are honored and their roles and contributions to family life and society are highlighted. In December, volunteers are recognized for their work and commitment to the Latino community. So it's not just about having workshops and the women out there. It's really a whole process that engages the whole community. Okay, so the first thing that I want to clarify is that this is work in progress. I do not have results that I can present, but I will be speaking to what I have learned so far from the partnership. So I met with AMICSCAN approximately 10 months ago. And since then, we meet once a week, except for the odd occasions. And on those rare occasions, we do a whole lot of emailing back and forth throughout the week. So there is a very strong commitment to this project. And I think that's one of the important things to recognize, that when you're working with community, you really need to have that very close working relationship. So when we began considering the partnership, I had recently started working at the School of Dental Medicine at ECU and was new to Greenville. So our first dialogues were really about the community at large. Then we moved on to talk a little bit about my research interests and background. We spoke about AMICSCAN, its mission, its programs, their other partners, and future directions. We spoke about the Latino population they serve, so the migrant farm workers and their families, the new immigrants, the established immigrants, and we spoke about the children. And contrary to my expectations, we quickly found overlapping interests. Our problem was actually that we found way too many overlapping interests. So we finally settled on one topic, but then we expanded it. Then we had to narrow it again, and then we expanded it again. And so this is the whole 10 months going back and forth on exactly what it was that we wanted to do. We finally submitted to the IRB, but we did have a few requests for IRB. So the first thing that we requested was a waiver of signed informed consent. We do not want to know if our participants are documented or they are not. That really doesn't concern us. We do want them to feel safe. So I mentioned before that AMICSCAN has become sort of a home for the Latino immigrants in Greenville. And we want it to stay a place where they feel secure, where they feel safe, with people that they can trust. So we requested the IRB to waive also standards of regular ethic training that you need to undergo. And we proposed that we would train the promotoras, we would train the people at AMICSCAN, so that we could do it tailored specifically to our study, that we could do it in Spanish, so that we could overcome that language barrier. For many of them, this is the first time that they're doing research, so we believe that with that, we're adding that additional research support. We also have ECU research team trainings and our dental examining calibration processes, and we introduce our non-Latino members to the culture and to the traditions of the Latino population. All our documentation has to be in Spanish, but the IRB does all the approvals in English, so there's a lot of translation also involved in the process. And the ECU team is actually doing the translations, but none of us are Mexicans. And so then that has to go through Amexcan so that they can make sure that it is appropriate for the terms that they use and so forth. And so finally, field work. So we haven't begun yet, but we will in a couple of weeks if all goes as we are planning. The value of our partnership, and I'm almost done. So the value of our partnership is really about creating that bridge between the Latino community, who is quite isolated in Pitt County, and trying to link them to the wider community, and Amexcan does this brilliantly. We also want to provide the Latino population with a means to be able to navigate that system, and so that's where the promotoras are going to be an important component of it. We're also, because we include community members that are non-Latino, so we're becoming more open to diversity, and we're learning in that sense. So we're focused on the oral health care needs of Latino and Hispanic children. We're basically looking at just to have a baseline of their needs. We're going to be doing some focus groups to look at barriers, and we're going to be looking at how their health impacts on quality of life and their growth and development. So those are our project components, which target each one of them. From there, I just want to highlight that we are using the special interest group of Promotoras for Social Justice, and this is because we believe that child oral health is really a matter of social justice, not just health. This is our study team. So we have the Amexcan group, and we have the ECU group. And moving forward, we want to be able to find out what we're going to do with the children that we find that might have some developmental delays, because that's one of our components. So where do we get services for them, or what can we do with them? Also, how do we move forward with the children that do need treatment to be able to get the treatment that they need? We've partnered with other institutions now, the East Coast Migrant Head Start and the ECU Agro-Medicine Institute, so groups that I had never thought that I would be partnering with, but it provides that whole holistic approach to our study, because it's agro-medicine, it's education, and so that's an interesting component that we hope to move forward with quickly. I want to acknowledge that the funding for this comes from internal funds, so it's all ECU sponsored. And while I did the Australian analysis, I had a National Health and Medical Research Council capacity building grant, so it was under that scheme. And I am going to leave you now with some photos from our Amexcan and ECU group.
Thank you. So maybe we have time if there's one quick question or comment.
My question to you and to Richard as well, because we talked about multi-sectorial partnerships, etc. You've given excellent examples. To those of you who don't know me, I'm Archana, originally from Nepal. And you mentioned earthquakes as well. And I'm thinking, we're talking about inequalities, etc. So is there any opportunity to partner with any one of you here to do something for Nepal, who has not only gone through inequalities throughout, but had additional burden post the earthquake? Thank you.
Well, what I've found that the easiest way to be able to establish those links is precisely to having someone on the other side that is interested. And so, you connect with these groups, and then what you can do is really has no limit once partners get together and start talking about issues. And so I think it's really a matter of identifying people in Nepal who want to work in certain areas with researchers here or anywhere else that have similar interests. I don't know if you want to add to that, but.
Can I react to that?
Sure, real quick.
Very quickly is that I have established partnerships with my workers where I worked with in Nepal. The problem is the funding, and I guess that's what my query was.
Oh, okay. Yeah. So part of what we've been able to do is with these community partners, some of them are willing to invest in small ways, but then you start adding up. So because it's this wide range of people. So we've got, for example, the Agro-Medicine Institute. We've got East Coast Migrant Head Start. And each one brings a little bit to the team. And so we won't have to pay for, the person that's a specialist in this or that, because they're already there. They're collaborating with us. That has worked for us. Not sure if that will work for, other groups, but that's our own experience.
So let's give our first presenters a warm hand.